Good evening, everyone, and welcome to Wellness Matters. Breast cancer is the most commonly occurring cancer in women and the second most common worldwide in terms of cancer. It also affects men, but to a much lesser degree, and they constitute about 1% of breast cancer patients. Treatment usually involves some type of surgery to remove the cancer, and consequently this leads to the removal of a portion of the breast. This is where breast reconstruction offers hope to the millions of cancer survivors worldwide. Tonight, Dr. Wisam Ismail, who is a consultant oncoplastic breast and general surgeon at the American Hospital, will walk us through the various procedures of breast reconstruction. Dr. Ismail, great to have you with us tonight.
Thanks, Maya. Nice for the invitation. Thank you very much.
Before we start, let's tell the viewers a little bit more about you. You are a UK board-certified general and oncoplastic breast surgeon with more than 10 years of experience. You received your medical degree from Baghdad University in Iraq and received training in the UK, Germany, and France.
That's correct.
So let's start first with the 10 quick questions.
Sure.
Are you ready?
Yeah, come on.
Why did you choose to specialize in breast reconstruction?
Oh, that's a very good question. I want a specialty that will work with cancer and will work with reconstruction as well. And to be trained as a general surgeon and have an oncoplastic training as well, this is kind of a new hybrid training for the last 10-15 years worldwide. And this will give the opportunity to remove the cancer and also to reconstruct.
What is the most satisfying thing about your job?
Yeah, well, the most satisfying thing, in my opinion, is that when you get the patient in your clinic and they are shattered and drained mentally and they're very scared of the cancer, and then you see them walk out with a smile after a few weeks.
Are all women good candidates for breast reconstruction?
I would say mostly yes, because the reconstruction is very well advanced now, and that goes into different stages as well. So I would say most of women are good candidates.
And can breast reconstruction be completed in one surgery, or would you require multiple surgeries?
The answer is yes, it can be completed in one surgery. So the ladies will sleep with the breast and they will wake up with a reconstructed breast with the same volume and shape, if not even better.
And what cases present the biggest challenge for reconstruction?
Well, the biggest challenge are the ladies who are going to go through lumpectomy and it's kind of a decent size. Then we have to mobilize the breast or take fat from somewhere else and inject it there. This is kind of a slightly relatively more difficult because you have the base, you have the breast, and you just need to reconstruct a portion of it, while after mastectomy, after removal of the whole breast, then it's relatively less difficult to reconstruct from scratch.
Is reconstruction, especially when you use an implant, what is the lifespan of the implant?
That's a very interesting question, a very common question. Well, I tell my patient that generally every 10 years, the implant needs a maintenance surgery. And that maintenance surgery means that, not because there's a problem with the implant, but as a body defense mechanism, the body will know that there is a foreign body in there and form a capsule around it. Over the years, this capsule will start becoming thick and start pressing on the implant, and that's what will change the shape or give the patient some symptoms like pain. So these are the two main reasons why we may need to do surgery. And sometimes we remove the implant and just take the capsule out and put the same implant back in, providing that it's not affected.
What are your top tips for choosing the right surgeon? Top 3 tips.
Top 3 tips. Okay, well, you need to do your homework before you choose your right surgeon. So look at their CV, make sure that they are board certified surgeons. Look at their experience, where do they get their training. Look at some feedbacks as well. I think these are the top 3 tips basically.
And what is your advice to breast reconstruction?
Well, my only advice is that don't be scared of having discussion about reconstruction, because breast cancer journey on its own is very scary and scarring. So to live with a psychological scar as well as physical scar for the rest of your life, this is not right. So come forward, discussion about reconstruction. Things are more advanced than 15-20 years ago, when most of ladies used to be like a flat-chested. Now things are more advanced.
Okay, perfect. Now, obviously, we are going to talk about reconstruction in detail tonight.
Sure.
But before we start, it's very important to talk a little bit about the breast cancer surgeries, such as mastectomy and lumpectomy.
Yeah.
Now, lumpectomy is a less invasive procedure. Let's start with that. And what makes a woman a good candidate for this surgery?
Okay, so, you know, these dimensions between the breast cancer in relation to the breast volume, it was important to decide about the type of breast surgery that we're going to go for. So small cancer in a big breast, big volume breast, that's a good candidate for a lumpectomy, or what we call the wide local excision. But a big cancer in a relatively small breast, there are some percentages. If you're aiming to lose more than 40 or 50% of your breast volume, then you cannot really have a lumpectomy. So you have to go for mastectomy and reconstruction. That kind of thing. Some cancers are more aggressive than others. Some cancers are not making a lump, but they go in between the breast tissue. Making a lumpectomy is less likely, then the patient has to go for mastectomy. So it really depends on the patient characters and the cancer characters.
Okay, so let's walk the viewers through a procedure, the lumpectomy procedure, first of all. What happens during such a surgery?
Okay, so we're trying to remove the cancer cells with some clear margins, normal breast tissue around it, to make sure that we've taken all the cancer out. And this is a simple procedure, but the more advanced oncoplastic and reconstructive surgery, making this simple procedure even better in terms when it comes to reconstructive and cosmetic. So now we're mobilizing a lot of tissues of the breast to fill the defect. We call it therapeutic mammoplasty. We do a liposuction, take fat from different areas in the body, and process it and inject it where the cancer was, so filling that defect, so the patient will sleep with a cancer, wake up with a tiny scar, but there's no big defect. And that even will make them, you know, getting the radiotherapy easier if they're going to need radiotherapy, which most of them do after lumpectomy.
Now, mastectomy is a more invasive procedure. Sometimes it involves removal of both breasts.
Correct.
If the cancer is on both sides. But again, in mastectomy, there are also various procedures that you can take depending on where the cancer is situated. Can you give us a brief idea of the various mastectomy procedures?
Correct. So previously used to be only a simple mastectomy. So you remove as much as you can from the skin as well as the breast. With the advanced techniques of oncoplastic and reconstructive surgery, we can spare the skin, so we can leave as much as skin as we need. We can leave the skin and nipple as well, so we can just take all the breast tissue from inside with a small scar, but we can still keep the nipple, keep the areola, and keep the rest of the skin and reconstruct it afterward.
Now, when is it advisable to go for breast reconstruction immediately with a lumpectomy and mastectomy? And when is it advisable to delay the reconstruction for a later phase?
Okay, so that's a very good question. For immediate reconstruction with lumpectomy, I think this is most of the time doable because we mobilize the breast tissue or take fat and inject it there. With lumpectomy is more doable as a one stage. But when it comes to immediate reconstruction after mastectomy, it depends on what we're going to do after surgery. Is the patient going to need radiotherapy? Is the patient going to go through more invasive treatment like chemotherapy? Is the patient fit for one-stage reconstruction, being a long procedure? Do they have any comorbidities like diabetes, high blood pressure, immunosuppressant? So this is what will actually decide about whether it's going to be an immediate reconstruction or a delayed reconstruction.
Now, going into the different types of reconstruction, obviously, maybe the one that people know more about is implant reconstruction.
Correct.
But there's also another form, which is autologous reconstruction, whereby
Definitely.
you use tissue from the patient's body.
Absolutely.
So is this harder or easier than the implant reconstruction? And how is the procedure? How does it take place?
Yeah, well, generally speaking, that's what we call an autologous reconstruction, which means that we're using the patient's body tissue, including skin, fat, and sometimes muscle, to give them the volume and reconstruct it. This is more advanced surgery, more technically challenging, and you need a lot of logistics and you need a lot of trained team to look after it. But the long term with autologous reconstruction, it doesn't need like a maintenance surgery like the implant, like every 10 years. If the autologous reconstruction went well and the volume is good and the patient is happy, then it's less likely that we'll need a revision or maintenance surgery after so many years.
And does the fact that the patient need, let's say, any radiotherapy after the mastectomy or lumpectomy determine whether you decide to do the reconstruction immediately or later on when it comes to autologous reconstruction?
Yeah, when it comes to autologous, there is plenty of factors. One of them is patient factor. Do the patient have enough volume from their skin, fat, muscles to reconstruct? And the other factor is, yes, what treatment they're going to have afterward. You don't want to irradiate your autologous tissue, although this will have a less effect than if you're going to use an implant-based reconstruction. So we put all these jigsaws together and to have the full picture, and then it's a mutual discussion. That's why the reconstruction patient needs to be very aware, and we give them all the options and let them choose.
So basically, if there's radiotherapy or chemotherapy involved, usually chemotherapy actually occurs maybe before surgery, or does the patient undergo chemotherapy as well after the or is it
chemotherapy
usually
can be at the
radiotherapy?
setting of neoadjuvant before the cancer surgery, or it can be on the adjuvant setting after the cancer surgery. It depends again on the biology of the cancer, fitness of the patient. Some cancers have more benefit if you give them the chemotherapy before the surgery, but some of them don't. And sometimes we don't know whether the patient needs chemotherapy until we take the cancer out and take like a sample of lymph nodes. And this will tell us if the lymph nodes are involved, then they're more likely to need chemotherapy.
So basically, would your recommendation be that if a patient needs radiotherapy or a chemotherapy after the mastectomy or lumpectomy to delay the reconstruction?
We don't call it delay, but sometimes we have what we call a staged reconstruction. So the three types of reconstruction that we have, either immediate reconstruction, so the lady sleep and wake up with a reconstructed breast, or a staged reconstruction. And that's when it comes to your question, if the patient can have radiotherapy, then we put a tissue expander that we're going to explain in a minute what it is. This will give us a bridge timing for the patient to finish their adjuvant treatment, including chemo, radiotherapy, and then we'll do the stage reconstruction with a permanent implant or autologous afterward. So tissue expander will give us some time.
Now, the autologous reconstruction usually takes tissue from which parts of the patient's body? What are the most common donor sites?
Well, the most common donor site is basically to start with what we call a pedicled flap. That means we keep the blood supply and we flip a muscle. There's a big muscle called latissimus dorsi muscle at the back. So this will be dissected and flipped to the front from under armpit, from the axilla. So by doing this, we're just dissecting the muscle, keeping the blood supply. This is what we call the pedicled flap. There is a free flaps. That's when you take a skin and fat from the tummy, from the inner thighs, from the buttocks. And this will give the volume, but that's what we call the free flap. So we detach the blood supply, but then this has to be re-implanted and re-anastomosed close to the breast into one of the vessels, just behind the sternum.
And this can be done in one procedure, harvesting the fat and then injecting it into the breast?
Yeah, it can be done. No, this is the third type, which you take a fat and you do a staged lipofilling procedure. You cannot inject too much fat at one go because your body has a limited capacity of how much fat it can give blood supply. If you inject like 500, your body only can take about 150 to give blood supply. If you inject 2 liters, still 150 to gain blood supply. So that's why if you're going for pure lipofilling and fat transfer for reconstruction, then it has to be like over sessions, usually about 3-4 sessions.
But the autologous one simply uses tissue without fat transfer, or are they combined together usually in the procedure?
That can be combined together, yeah. So you can use the LD flap and inject the subcutaneous fat and even the LD muscle with fat, basically. So this will keep it pure autologous. Sometimes there is a hybrid module, so you lose your own body tissue, but because there's not much enough volume, then you can put an implant underneath it. So this can be autologous and also implant-based reconstruction. So all that, the options are very, variable depending on patient parameters, patient choice, pathology, and what the patient is going to have in terms of treatment.
If the patient is a young patient planning maybe to get pregnant later on, does that affect what kind of reconstruction you advise, or what kind of the donor site for the tissue?
No, not necessarily. Pregnancy, the only thing that's going to affect on the breast is the breastfeeding. Obviously, it's going to be a mastectomy then. Even with the reconstruction, the breast is losing its own function. But there are certain types of breast cancer that is gone through the genetics mutation, like a BRCA1 and BRCA2. And the problem with those, that's not only affect the breast, but this affect the ovaries as well, as much as affect the breast. So if the patient, for example, have a BRCA1 or BRCA2 mutation, their chances of having ovarian cancer is probably 60 to 70%, as well as the same as breast cancer. So if they're planning to have kids afterward, then that needs careful planning. They need to go through, for example, egg banking or egg preservation, and then the ovary is removed, and then when they're ready, this can be reimplanted into the uterus. So it's a long process when it comes to those organs.
That's mainly due to the radiation that the patient has to undergo.
To
harvest the eggs, it's better to harvest the eggs before radiation and
no,
chemotherapy?
not for radiation. Sometimes you can do that with chemotherapy.
Yeah.
But if the patient have the genetic mutation, which is BRCA1 and BRCA2, this is genetically going to affect the ovaries with ovarian cancer, nothing to do with breast cancer.
Okay.
So it affects both. That's why we need to deal with both. So
this is actually what Angelina Jolie did.
Absolutely, yeah. So she had what we call a risk-reducing surgery, which means that you target the breast before the cancer hits in, basically. So they remove the breast and reconstruct it, because if you got this gene, then 7 out of 10 ladies will have cancer, very, very soon.
Well, it's good. At least we know what gene to look for if the person is interested to look for it, and then decide accordingly whether or not to do any preventive surgeries.
Definitely, and there are certain parameters. If you've got a long family history from one side who's got breast cancer at young age, this will trigger, the genetic factor. So that's why we have specific tests to test for those. And it's not only BRCA1 and 2 genes, we test variable genes that can also affect the breast cancer and ovarian cancer.
Now, let's talk a little bit as well about recovery time. So with the autologous and fat transfer procedure, what is recovery time for the patient after the surgery?
Generally speaking, with autologous reconstruction, because it's more advanced procedure, it has a donor site and a recipient site, effect, then the recovery will be longer for autologous. For implant-based, it's one site. It's kind of less advanced technically procedure. Then the recovery will be quicker and easier.
Now let's talk about the implants. We have quite a few samples here.
Sure.
So usually it's a shorter procedure as well, even if, is it always in one surgery or is it also staged when it comes to implant surgery?
No, it's all of those. So it can be one surgery and it also can be a stage reconstruction. So I'm just going to take you through the different types of implant that we have, and we go through the expanders. So basically, we have the most common types are the round implants, so the implants that are symmetrical in the width and height, like a dome. So this is what we call the round implant. The other type of implant is the type of implant that we call it a anatomical implant, and this is like a teardrop implant, and you can see that there is a lower upper pole volume and there is a higher volume at the bottom end. And the third type is the ergonomics, which is round when it's flat, but it kind of gets as a teardrop when it's opposed against gravity. And this is one of the newest one, and it even has a kind of a chip that will give all the information about the implant, about manufacture, when it was made, and that kind of things. And those are mainly the three types of implants in the market, and they also can go between smooth, microtexture, and textured implant.
But the chip doesn't track you, right?
No, chip doesn't. It doesn't beep in the airport.
Okay, that's good to know. Basically, what it does, it transmits information about the lifespan of the...
It gives a lot of information, and some of the important information is, for example, if you've got an accident or the implant is ruptured, and you don't know when you've done it or when was that manufactured. So this will help to improve the quality and to help to tell the manufacturer, okay, that was been made at that year from that batch, sent to this country, and then put on such and such patient as well, providing that all the database has gone in correctly.
Where does privacy play a role in this kind of implant?
No, not much really. This is, I think, all to do with the quality improvement. Most of these implants will come with a warranty because the company wants to make them more durable. Some of the companies even offer to replace them free of charge if you give them the old ruptured implant, because they need to do some test on it to check why it's ruptured, while when they say the durability is about 20 years, 25 years, but then after a few years it's ruptured, so, or punctured. So that's where they that comes with the quality improvement.
Okay. Now, we have to mention here as well that with a maybe double mastectomy, for example, where you've removed all the skin and the nipple as well, you would need skin expanders before you can implant maybe the implant. So can you explain how this works?
Sure. So basically we have two types of what I call the tissue expander. So this is kind of an oldish style, but some people are still use it. This way called a tissue expander with a remote access. So that port here is when we inject the fluid to expand the skin, and that usually goes into the side of the chest or in the abdomen, just under the skin. The newer module, that's what we call an integrated port tissue expander. And this is kind of advanced and doesn't have a port. And what we usually do, we put it as a deflated one in theater. And then when the patient comes to clinic, when everything heals up, then we have what we call a disc detector. So this small device will tell us exactly where's the safe point to inject, and tells me here that this is the middle of the disc. And in clinic, we can inject through the expander very safely. And this will, over the weeks, expand the skin to the degree and to the volume that we want. And by that time, the patient will be ready for the exchange of expander to an implant surgery.
And so after expanding the skin, the implant can then be placed in the right position?
It serves two purposes. It's expanding the skin as well as bridging the patient through all the adjuvant treatment that they need, which can be chemotherapy, radiotherapy, mainly radiotherapy, because we don't want to put an implant and get that irradiated, because this will speed up the process of capsular contracture. Instead of becoming, instead of being 10 years, it can, make it 3, 4, 5, 6 years, basically. Then the patient may need revision surgery then. So bridging reconstructive staging is very, very important stage.
Now, with implants as well, you have a procedure where you either put it over the muscle or under the muscle.
Correct.
So what determines whether you put it over or under the muscle?
That's a very good technical question. So usually with reconstruction, in majority of cases, we put it under the muscle because we want to protect the implants. With the new technologies, with the new techniques, then we started putting it over the muscle. So we call it, pre-PEC implant reconstruction. And this is with the advances of the coverage that we put over the implant, like the meshes we put it. Basically two types of meshes, either a prosthetic mesh, which is a titanium-based mesh that we use, or it can be what we call ADM, acellular dermal matrix, which is a normal skin that comes from animals. They take all the cells of it to prevent any reaction, and this will provide a full coverage over the implant. So all these technologies provide us with a new concept of putting the implant over the muscle, rather than to lift up the muscle, new plane, too much pain. Then it's we're verifying the anatomy, and pre-PEC implants are becoming more and more reliable and more advanced.
Now, in terms of risk factors, does where we place the implant, whether under or over the muscle, have any different? Like, is it which one is more risky?
Well, putting it over the muscle is riskier because there's nothing protecting it under the skin apart from the mesh that you put in. So we have a very small windows about when to choose the patient for a pre-PEC implant. The patient needs to be young, fit and healthy, kind of non-smoker, not much of comorbidity like diabetes, heart issues. So the windows of choosing the pre-PEC is very, very specific and limited, because if anything goes wrong, then the implant will be eroding through the skin, or there will be an infection. That means that we have to take everything out and start from scratch. So it's a very unpleasant experience if that happens. So that's why it's a very strict rules about when to choose the pre-pectoral implants.
Okay. But I mean, after saying that, I would personally think the one under the muscle is just safer, even if the pain is more at the beginning.
Correct. Yeah. But the long-term results show that even if you put it pre-PEC, you're preserving some of the function of the PEC muscle, because to put the implant under the muscle, you have to dissect, from the inner side of it, and this can make it slightly weak, give the patient some pains when they move. When they move and the implant is under the muscle, then this can be shown, and that's one of the ways to test where the implant is. The patient don't know, basically, after many years. Okay. Ask them to press against the waist, and this will contract the muscle, the implant will go down. You won't have these animation if the patient is having the implant under the skin. It will be more, free from the muscle, so it's not going to be affected by the movement of that muscle.
Now, with today's technology as well, there's a system, the Chrysalix 3D animation, which will allow the patient to see what the implant that they have chosen might look like before they actually undergo the surgery. So can you show us that system? Explain to us how it works. What would you show the patient?
Yeah, so that's the importance and the beauty about the artificial intelligence. So with the advanced technology, we can even talk to patient and see what they want and show them even the pictures of the reconstructed breasts even before they go under the knife. And that's the beauty of it, because the concept of patient having surgery, it might be different when they're trying to explain, but when they see it from different angles, that will be great for them. And you know, we're reaching the expectation that the patient wants as well. So we can go through and have a look at this software together, if
please
that's okay.
Show us, please.
So before we start, this is an animation. So this is a software that's animated this chest wall and breast tissue. So this is not a real patient, and this is the dummy from the software company itself. All right. So basically, on the left-hand side, this is the normal breast. On the right-hand side, that's what we're going to show the patient that we're going to reconstruct it. So if I want to put implant here, and it can give you the numbers. So I'm putting, like, for example, 300 and 370 cc on this side, and it can do the same on the other side. And that's the volume of implant, for example. So if you're going through 370 for both, so you can see the difference between the left picture and the right picture. And this way we can show the patient from different angles. So if we go around, then the patient can see how it looks from the profile, and it also can give you how it looks from the top, from the sides, from the other side, 45 degree, and we go back again to the front. This helped a lot to give the patient the vision about how it's going to look like. And also we can uplift it, we can show the patient where the scar will be. We can draw the scar and tell the patient how it's going to look like after a few weeks and months and years, because even the color will fade according to the patient's skin color. So what this software does, it takes 3D images of the patient, reconstruct them, and then we can work on them on the patient body themselves on the screen to see exactly how they're going to look like after any reconstruction or even cosmetic surgery.
And it also helps the patient basically choose the size
Absolutely.
of implant that they would want to put in, because seeing it like this might not give you and help you visualize the actual final look.
Totally correct, because the patient, yeah, these numbers that we talk about doesn't mean anything to patient. They want to see live how it's going to look like, and that's why it gives you a different angle where you're going to look like it from. So, and that's what the patient likes. And this software and this new technology is helping the surgeons, helping the patient to reach an agreement about, okay, what's the approximate size that we would really like to have.
Now, obviously, does having the reconstruction, whether implant or autologous, affect future possibility of diagnosing any cancer that might recur?
That's a very good question, especially when it comes to cosmetic breast surgery like augmentation. The implant, usually we need to put it under the breast itself or under the muscle, so it shouldn't touch the breast tissue. There is a misconception that, yeah, if you go for breast augmentation with an implant, then this might affect the mammogram or ultrasound. Mm-hmm. It usually doesn't, because that goes totally under the breast, so the breast tissue will be free. And even if it goes under the muscle, you know, you still can have a normal mammogram test and an ultrasound scan test. Sometimes when you do a breast reduction uplift, then you can see scarring. And sometimes in some wrong techniques, there are some surgeons who inject the fat into the breast tissue itself, and this can confuse the radiologist, because then you don't know whether it's an actual lump or this is a dead fat lump from the injection. Mm-hmm. So what we tend to inject is under the skin, under the breast, and within the muscles. So we're trying to avoid the breast itself. And this will give the same result with a safer option and better screening for the patient.
Now, obviously, when we think of breast cancer, we always think of women. But let's not forget that 1% of breast cancer patients are also men.
Absolutely true.
So to what extent do you see those patients here in the region? And what does the surgery to remove the cancer for men involve?
Well, surgery is very rare. It's about 1%, as you mentioned earlier. And when it comes and the cancer hits the man, it's usually very aggressive. And that requires most of the time what we call the total mastectomy, by removing the breast and removing the nipple and areola, because the breast tissue mainly are just under the nipple for the men. and when the cancer hits, it's going to hit in that area. And most of the time we have to remove the nipple areola and part of the skin, and patient usually needs chemotherapy. And then the whole family will be alerted, because male breast cancer most of the time is genetic, so they have to go through genetic testing as well.
Last but not least, let's talk a little bit about nipple reconstruction. Whether for men or women, sometimes you are forced to reconstruct the nipple, and this is where usually a staged reconstruction is necessary. So how is the nipple reconstructed?
Well, once you've gone through the first few stages of reconstruction, for example, putting an expander and then change that to an implant, and then when everything settles down, we construct the nipple from the skin. So it's basically a skin flap from the patient's own skin. We dissect it and stitch it in a way that will make it look like a nipple, but it doesn't have any sensation, but will look like a nipple. And when everything heals up, then we'll tattoo around it. So that's a kind of one type of nipple reconstruction that we do. The other type is a prosthetic nipple that the patient can have. And the third type, with the more advanced tattooing, the patient can have what we call a total tattooing of a nipple and areola, and give a shadow underneath it to make it like a 3D nipple. So it's all flat, but it's all drawing and tattooing basically, if the patient doesn't want to go through like a small surgery for nipple reconstruction.
And it's also important here to note that a lot of women are electing to stay flat after a mastectomy or lumpectomy, or maybe sometimes to use prosthetics as well. This is also an option. Yeah,
correct. So not all the patients are willing to go through reconstruction. Some of them are happy to stay flat, and they are in peace with their body, with themselves, but they want to get on with their life and they don't want to look odd. So there are plenty of implants or something similar to implant. We call it external prosthetic. They can put in the bra, and in the clothes they will look normal because they come in different shapes and sizes, and that's available to have and buy as well.
Dr. Ismail, thank you so much for this in-depth discussion of breast reconstruction, and I hope we were able to shed a lot of light on the different options available out there to cancer patients, breast cancer survivors out there. And in the end, before I conclude, I would like to say that hope is a powerful thing. Hang on to it and to the people who love you and will lift you up no matter what. Join us next Tuesday at 8:30 p.m. with clinical psychologist Dr. Karine Bakhazi, who is also the director of the psychology department here at the American Hospital in Dubai. And remember to like this episode on Facebook and to subscribe to the American Hospital's YouTube channel. Have a good night.